Hi everyone, my name is Dr. Antonio Berto. I'm a full-time endodontist in Dallas, Texas. Today, I'm very excited to talk about a novel procedure called pulp regeneration. It is true that back in the 70s, Dr. Nick Garosby was able to regenerate vital pulp tissue, but he was unable to do so when the pulp was necrotic. So today, we're going to be discussing this technique to where we can predictively allow the pulp to regenerate. So during this presentation, we're going to be talking about what is regenerative endodontics, what is the biological basis for regenerative endodontic therapy, what are the considerations for clinical regenerative endodontic procedure, and what could regenerative endodontic looks like in the future. So if we were able to bring a necrotic case into a vital case, that would be phenomenal. I truly believe that in the near future, that's going to be definitely a treatment option. And what is regenerative endodontics? Regenerative endodontics is a biological-based procedure that will allow us to predictably replace damaged tissue and restore the normal physiological functions to the pulp-dentin complex. So when we look at this case, historically, what we will try to do is using multiple visits of calcium hydroxide to obtain a plug apically and eventually fill the root canal with our carapace or filling material. The problem with this treatment is that we will need multiple treatments with calcium hydroxide. The patient will have to be compliant, and then multiple changes of calcium hydroxide have been shown that will debilitate the mechanical properties of dentin. Another alternative is doing an MTA plug apexification, where we can, in one single visit, fill the root canal with MTA. That MTA has been proven to allow growth cementum around that area, and the studies show up to 95% success. But neither of those two techniques are going to allow us to get any growth on thickness and length on the weak roots. So let's have a look at this case. This is a case from my friend in Ontario, Canada, Biraj Bora, and it shows us how the open apex tooth has a huge potential of regeneration. This number 8 was a bulge on the kid's grandfather's garden, and luckily his grandfather is a dentist, so he was able to reimplant the tooth right away, and after that they went to Dr. Bora for following up. As you can see, on the pre-op and the 3 weeks follow-up, there is no pathology pre-apically, and then in 5 weeks we can start seeing root development. Again, there was no need for endodontic treatment, and the pulp was able to regenerate by itself. This is a different scenario. We have already an established infection on an open tooth with apical peritonitis. So when we think on those teeth, they are very thin, very prone to fracture. And what we're going to go through, it's a technique to stimulate new tissue inside of the tooth. So when are we going to do this procedure? First of all, we need a tooth that is necrotic with an immature apex. Then we need that pulp space not being needed for post, core, or final restoration. Definitely a very important thing is that the patient is compliant, especially their guardian. And finally, the patient should not be allergic to any medicines or antibiotics. As far as the consent form, we're going to make a 2 consent form for 2 appointments, and we're going to inform the patient that we're going to be using antibiotics. And then the possible adverse effects, at first the staining on the crown or root, and then the lack of response of treatment. So in the first appointment, we're going to get the tooth numb, as we will typically do with local anesthesia, typically lidocaine and epinephrine. We're going to isolate the tooth with our rubber dam, and then we're going to access with our ramper and our Endo-C, as we typically do. And in this technique, we're going to rely on the chemicals to disinfect the tooth. We don't want to instrument those very thin roots to debilitate them even more. So again, we rely on our irrigants to do the disinfection. So for us to get as effective as possible, we're going to use a negative pressure device. And there's multiple negative pressure devices in the market. I like to use my own one since it's a little bit less complicated than the ones on the market. The way I did my own negative pressure device, it's just using our regular sodium hypochlorite, and then we're going to use an open side vented needle like a MaxiPro needle, and then we're going to use an empty tube of either ultracal or EDS, and then a small navy tip. And that's how we're going to set it up. We're going to irrigate with our regular MaxiPro, and then the suction is going to come from the apical part of it. And that way we can deliver our irrigants in a very safe way. And then we will place calcium hydroxide or a low concentration of a triple antibiotic paste delivered into the canal system via syringe. And what is the triple antibiotic paste? It is a mix of ciprofloxacin, metronidazole, and minocycline. My personal recommendation to avoid crown staining is to substitute the minocycline for augmentin. And then on the second appointment, it's very important that we use anesthesia without epinephrine. Why is that? We want to induce bleeding on the canal, so the vasoconstrictor can have a negative effect on the bleeding. So you think on using something like mepivacaine for that. Once the tooth is numb, again, we will go back and irrigate really good. And as a final step, we want to use Q-Mix so that we can remove the smear layer and get all our blood clot inside of the dentinal tubules. And something very important as well, again, we need to remember that we are relying on the chemical part of the irrigants to disinfect the canal. We're going to use the endoactivator for that regards to move the irrigants around. And then before finishing the procedure, there's something, a little trick that I always like to do to avoid crown staining, and it's drying the canals. Then we're gonna etch the crown. Then we will use our bond and seal the dentinal tubules on the coronal aspect of the tooth. So once we have that, here comes the more critical part of the case. We're gonna get a hand file like a 30 or 35, and then we're going to intentionally go past the apex, okay? That's going to induce the bleeding, and it's a very critical part, okay? Once we have the blood start going coronally, we want that blood to clot around the CJ level. And then once we have that, my recommendation is use a collagen plug to prevent the MTA going too far apically, because we want to keep that MTA as coronal as possible to allow the more apical part to continue follow. And the way to deliver this MTA, it's the easiest and the more control we'll have, it's with a MAP system. Okay, it's like a little small amalgam plugger, but under the microscope you're going to have much more control. So that's the way we will be delivering the MTA on a very controlled environment. And finally, we're going to end up restoring the tooth. We can put a thin layer of glass ionomer so that we don't have to wash out the MTA, and over the glass ionomer we'll place our resin for amalgam restoration. So we have seen the animation part of it. Now let's have a look at the real life, okay? This is our patient. She's a 12-year-old female Caucasian patient, and she came to our office with this open apex tooth. When we did our vitality test, the tooth didn't respond to cold and was slightly sensitive to percussion. So our diagnosis was pulpal necrosis with symptomatic apical peritonitis. When we accessed the tooth, we found basically what we were expecting, a necrotic pulpless tooth. We irrigate, we place our medication, and that's the final x-ray and the final picture with a resin type of material. The reason why I chose that color resin material, well, we can seal the tooth better. It's very important, as we will talk further, to obtain a really good coronal seal. And then on our second visit, again, we irrigate really good. We induce the bleeding, we place our collagen matrix, and then pack the MTA against it. And that's the final x-ray showing the MTA, and the final restoration. So when we look at the tooth from the pre-op X-ray to the follow-up, we can start seeing some healing, and then 3 months later, the apical area was completely resolved, and what we were not expecting is this fantastic result at 2 years, where the tooth seems like a normal tooth, completely developed. So again, we went from a basically guarded prognosis and prone to get extracted tooth to a completely normal, healthy tooth, fully developed, responding to all vitality tests. And that's our main objective when we try to do this type of treatments. So now let's talk about some questions that it may arise. What are the factors for success? What are the clinical outcomes? What is in the canal space? Is it truly pulp? What are the potential complications? And let's talk a little bit about case selection as well. So there's 3 very important factors. First, disinfecting the root canal. We have stressed already the importance of our chemicals to disinfect the root canal. We're barely going to be using our endodontic files. Second, we're going to use a matrix so that it induces the proliferation and differentiation of the pulp tissue. Okay, that's going to come from our blood clot. And finally, and most importantly, we want to seal our coronal access as good as possible. Okay, and that's where the MTA and our composite are going to come into. And then as far as the outcomes, most of the studies that we have, unfortunately, are case series. So level of evidence is not great, but on most of these studies, what we found is that there's absence of clinical signs and symptoms. There's radiographic evidence of resolution of the infection. We continuously see root development and increase of the wall thickness. And a very recent study shows that there's significantly greater increase in root length and thickness when comparing this treatment to both calcium hydroxide or MTA apexification, and that's something to be expected. When should we expect the outcomes? There is a variation between 3 to 21 months for the lesion to heal. There's an average of 8 months for that. And then as far as root development, typically it's going to happen within the first 2 years. And here on this histological slide, we can see what happens inside of the canal. Okay. Unfortunately, on dog studies, which is where we've been able to do so, what we're seeing is not true pulp tissue, but cementon type of tissue and bone-like type of tissue. So those black arrows are cementocytes, which are precursors of cemental cells, and then the blue line are cementoblasts creating cementum. What are the potential complications? Sometimes, unfortunately, this treatment, as any other dental or medical treatment, is not 100% successful. So in certain cases, we're going to be unable to induce bleeding. On those cases, I would recommend you to place the medication one more time and bring the patient back. If the MTA placement goes to apical, you can always wash it out and try to place it again. Again, we have explained you how to prevent that by placing the collagen barrier. We have also discussed how to avoid tooth discoloration, and then we'll talk in a second about case selection. So tooth discoloration happens for 2 reasons. One, if we use the tetracycline, and we can change that for augmentin or just do a double antibiotic paste. And then again, we mentioned about bonding the coronal part of it with an adhesive to avoid the discoloration of the formaldehyde that is released from the composite type of materials. And this is something I call 50 Shades of Gray, because if you don't get to prevent those, we're going to have this type of gray discoloration. And since that movie just came not so long ago, I thought it was funny. This situation is something where we can actually counter it back and do internal bleaching, and typically the internal bleaching is going to have really good results on it. And finally, let's talk about case selection. In this first case, it's a very or relatively recent case that I did. It's a one-step revascularization. There's already literature. The Journal of Endodontics by Sin et al. saw how you could get revascularization in one visit. So that's what we did, and on the first visit, we placed our MTA and followed the technique that we just talked about. On 3 months, we were already seeing regeneration and the lesion completely healed, but unfortunately, the patient came back with this situation. I truly believe that there was a problem, the communication between us, the general dentist, and the patient. It's something very important that both the patient and the general dentist are informed that those root canals, well, that's not an ideal root canal. It's not going to have the appearance of a regular root canal. And as I'm telling you, the referral doctor probably thought it was a bad root canal, referred the patient somewhere else, and the patient came back with a completed root canal, but that's completely against what we were looking for. So when we see this case, we have the pre-op and a 3 months follow-up where things have healed really good, and then we see the 6 months follow-up. My face was as sad as my kid watching the last World Cup where Spain didn't win a single game. And finally, we have an ortho case, courtesy of Dr. Chan's Choate in Houston. This kid went to the Houston Dental School for orthodontic treatment, and Dr. Choate got this case after the treatment was done. So because of his occlusion, they wanted to extract premolars, and when we have a really close look at this case, you can see that the second maxillary premolar on the right side has a little defect on the occlusal side. That's how we typically see dents in dente. It's very important that we do a very careful clinical examination, because if we're gonna get to extract a tooth, we typically want to extract the one with pathology. So unfortunately, there was no PA taken, and Dr. Choate got the case just like this. He was able to see sinus tract on the gum area when he got this case, and referred the patient back to the endo department at Houston. So they were able to do a pulp regeneration technique, and here you can see how the crown, it's a little bit stained, and that's basically what we were talking about earlier, and they could prevent that step following what we said earlier. So let's summarize what we have talked about. Regeneration techniques are going to allow us to get fully development on a necrotic tooth with immature apex, and the way we're going to be able to do so is by doing a proper access cavity, disinfect the canal with our irrigants, and then seal the coronal aspect with our composite. And then on a second visit, we're going to be able to induce bleeding, and that bleeding is going to be our matrix to get pulp tissue in the canal, and we're going to pack our MTA to seal the canal coronally. I hope this lecture was informative to you. Please do not hesitate to contact me to my email, bertoendodontics@gmail.com. Thank you.